Hey, y'all. Don't forget to sign in. Make sure you sign in to. Don't forget to sign in. Okay, I see 61 participants and I see 12 chats. You guys need to sign in to get credit for being here. This is especially important if you're receiving financial aid. All right, did everybody at least start studying for this and look up the exemplars and assessments and interventions and things? Okay, so if you haven't already, if you put them in linear sheets, okay, I would suggest after this class that you move them to, if you have your virtual wall or a sheet of paper where you can see them side by side and maneuver interventions and like assessments to one single column that will have more things in it, and then smaller areas. You're going to have to work with this stuff so that you become familiar and can make those links and associations. Okay. Things like if I say bowel rest, you're going to know that that means that there's going to be no food or anything passing through the bowel into the GI tract. Okay, not even enteral feeds, because bowel rest means the gut needs to rest. Okay, and that there possibly could be an NG tube involved. If I say NG tube, to even get out the gastric juices and anything that's going to be in the stomach that can cause nausea, vomiting, and just to help it rest. Okay, so when I talk about weight, y'all should know that from the last time, but we'll go over that now. Okay, so it's after 10:30. So again, here's your paper with common assessments, with the interventions that are going to go with it, and then your exemplars across. And we're going to start with GERD. Okay. First, we'll start with the common assessments. What's one of the things you're going to do initially when you walk in and identify the patient? You're going to what? Take their what?
Vital signs.
Vital signs. Good. How often you take them is going to be mirrored by what their status is. If they're in ICU, it may be every 15 minutes to every hour. On the floor, it may be every 2 hours. It may be every 4 hours. It all depends, okay? Depending on what you're looking for too. If you're looking for pain, you know, their respiratory rate maybe go up a little bit, their heart rate and their systolic blood pressure, okay? If they're dehydrated, what's gonna happen? What are you gonna say?
Low HbA.
Elevated lab levels like sodium.
I'm talking vital signs.
Oh,
You're gonna see low blood pressure.
Okay, low blood pressure and an increased heart rate. Okay, sorry, that's my daughter coming in and my dog's coming to. Okay, so be mindful of those kinds of things. You know, you give them pain medicine, respiratory rate's gonna come down, their heart rate should come down some, and their systolic blood pressure, okay? When you give them fluids and they start to normalize with their hydration status, same thing. So when we're talking about hydration, you know, we're gonna look at those fluids that are being given, okay? And what assessments are gonna go with hydration?
lab.
Skin turgor.
Okay, skin turgor is only as good as, you know, the elasticity of the skin. In elderly, it's not very good, right? So you're gonna look at things like mucous membranes, you know, their tongue, is it tacky? Are they dry? You know, peripheral pulses. When they're dry, what? You said their blood pressure is lower.
It's low, so they're gonna have faint pulses.
Okay, not so much faint, but they're not going to be as strong, you know? So yeah, they could be a little weak. Okay, a +1 as opposed to a +2. Okay. Also what?
Extremity strength and
No,
Swelling.
not for dehydration unless they're third space and kind of, you know, the urine.
I'll have tachycardia. Oh, I'm sorry.
Right, their pulse will go up. We talked about that, but their urine is going to be dark, right? Because the body's going to want to hold on to as much water as possible. So the urine's going to have increased osmolality. Okay, it's going to be darker, and it may not. If it's 30 cc's or 30 milliliters an hour, you're going to be lucky. It may be reduced a little bit. Okay, so you're going to be looking at that INO. What is the hallmark, or what is the most accurate way to assess hydration status?
Their weight
Their weight. And when are you going to do that?
in the
In the
morning
morning,
before after their first void, before eating
before
breakfast.
breakfast.
What else?
Same clothing.
Same
Same
clothing, same scale. Yes. Okay. So that's going to tell you a lot. If they're a bed scale, okay, if they're you're weighing on a bed scale, you're going to have to take off all the extra pillows, all the extra blankets. It's going to be the bottom sheet, the pad, top sheet, blanket, a pillow, and a pillowcase. Okay. If there's something hanging on the bottom, such as for plexi pulses or SCDs or something like that, that has to come off. Foley has to be emptied completely. Okay, and so all that stuff has to be, you know, negated as far as any extra weight, cell phones, all that, all the superfluous stuff out of the bed to weigh them accurately. Hopefully the admit was accurate as well. Okay. Also for these exemplars, it's going to be a focused abdominal assessment, and then probably going into respiratory because it's right there, right? And then if they're having any problems with electrolytes such as potassium, you'll go to cardiac and make sure they're not having any kind of arrhythmias, right? Perfusion problems. But if they're having any kind of ascites, okay, that's third spacing into the abdomen with a fluid shift from cirrhosis with hepatitis, okay, chronic hepatitis, chronic pancreatitis and necrosis, anything like that, they're gonna, you're gonna need, okay, to monitor their respiratory status because it's gonna what? Why is the respiratory gonna be affected?
Because the fluid's going to push on the diaphragm, making it harder to breathe.
There you go. All right. One of the things that also is all the way through these exemplars is what? One of the 6 signs and symptoms. Gonna assess for pain, PQRST, and the meds that they use for pain are gonna vary somewhat. Okay? And then where the pain is located and what aggravates it, all that kind of good stuff. You're gonna want to keep the head of the bed up at least 30 degrees. All right? You're gonna assess, like I said, assess that abdomen. We went through it last week, but you're also gonna look for bruising, which are telltale signs for pancreatitis. If it's bruising around the umbilicus, it's going to be Cullen's sign. If it's in the flank, it's going to be Turner's sign for pancreatitis on that right-hand side. INO, you might have to monitor the INO every hour for a while, especially if they're dehydrated, you're given fluids. Okay, you want to make sure if they're on enteral feeds and they're getting Lasix for some reason, you know, they have edema in the interstitial spaces. You're gonna, you know, you need to really watch for dehydration. You want to have them turn, cough, and deep breathe every 2 hours. If coughing is contraindicated, you know, at least deep breathing and turning. Incentive spirometry, Q1 hour while awake. If I say they're on bowel rest, they're going to be NPO. If they're NPO for more than 2 to 3 days, they're probably going to be on TPN. If it's a swallow issue with nutrition in the gut, then they're going to be on enteral feeds, and we went over that. So make sure you know the nursing care for the TPN. Also teach and reinforce, a lot of teaching with these. Okay, and you're going to reinforce that teaching. We want to prevent further injury. We want them to take their meds as prescribed, maintain nutrition and fluids. Okay, they may have to change their lifestyle and their diet and be able to teach the family how to assist with the caregiving. We want to encourage ambulation because that's going to help them get better as well. Keep up their strength. Collaborative, again, the nutritionist or dietary, physical therapy for chronic inflammation associated with aging and obesity. Surgery, they may have to remove parts of the colon and the rectum and or give them or parts of the colon if it's an obstruction in the small bowel from Crohn's, and give them an ileostomy or a colostomy. That's going to determine what kind of stool is in that bag. Okay. And then the farm therapy, medication therapy to decrease the inflammatory response and decrease the pain. Also, when we need to administer antibiotics. And then we're going to talk about the complications therein. Okay, so with GERD, assessment? What are they gonna come in with, you think? If they come into the ER?
Chest pain.
Chest pain, heartburn.
Pain that they're gonna
Okay.
describe
Pain
how
is-
to say it, like chest pain.
Yes. And it's gonna, what we call atypical chest pain. But if it's chest pain, what are they gonna, what's gonna happen in the ER?
EKG.
Okay, they're gonna rule out cardiac involvement, right? That's the
Mhm, right.
first thing they're gonna do. They're gonna hook them up to, not an echo, they're gonna hook them up to an
EKG.
EKG, right? They're gonna hook them up to a monitor and look for, you know, the PQRS,
Yep.
the ST elevation, all that kind of stuff. They will draw labs. They'll get an IV started and they'll draw labs, but they're going to get a set of vital signs because they need to before they can give any kind of meds for cardiac, if it's cardiac. But talking about GERD, you know, it's not going to be cardiac involvement. So they're going to start asking questions, even when they think it's cardiac involvement, or they may suspect, you know, when did it start? Did you eat a large meal? What was it? You know, what were you doing when the chest pain started? Does anything relieve it? You know, how are they breathing? Because typically with cardiac, they're going to have the shortness of breath and stuff. Now they may have a little shortness of not shortness of breath, but they may be breathing a little bit because of the pain and the tightness and just the anxiety that they're feeling, because they're feeling chest pain, right? And they don't know what's causing it. So all those other questions about the meal, what they had, you know, when the chest pain started, all those kinds of things. If the symptoms increase when they're bending over or lying down, those are all very important, okay? And GERD occurs from an incompetent lower esophageal sphincter, the LES, or increased pressure within the stomach, okay? That also impaired esophageal motility and decreased saliva production. So all those things make, you know, make a difference and show you how GERD occurs. So it's very much related to the stomach because it's the acid and the gastric juices that come up and cause the pain and the irritation, the burning, the aching, all that kind of stuff. So in the ER, they're going to give them a GI cocktail. Usually it's going to be bismuth or sucralfate, milk mag, something with a coating property to it. Could have some bentyl in it, which is helps with the motility to some degree, mostly intestinal, okay, or like a colic, so to speak, okay, and viscous lidocaine. And what it does is it coats and numbs the esophagus and into the stomach, and they should feel relief. Okay, they may even belch and feel better. Okay, so all of that, you know, then they're gonna tell them to go see a GI doctor. Once they get to see a GI doctor, he's probably gonna have them make appointment for an EGD. Okay, an EGD is an esophagogastroduodenoscopy. Okay, which is basically a scope that goes down through the mouth, down the esophagus, into the stomach, so that they can see the lining of the stomach, the lining of the esophagus, and into the duodenum. Okay, esophagus, gastro, stomach, duodenum, or for the duodenum, and scopy for being able to visualize. So when the doctor, he or she goes in there, they're going to be able to see redness. They're going to be able to see edema, any erosion that's taken place, any ulcers in the stomach, whether it be the gastric or the duodenal. You know, be able to look at that lower esophageal sphincter. That's the hallmark, because they're able to directly visualize and take whatever biopsies they need. Okay, so risk factors, what increases the incompetence of the lower esophageal sphincter or increases the pressure within the stomach?
Repeated, drinking carbonated drinks.
It can, but not so much, because that's I mean, it'll cause gas, which will cause distension, but it's not going to actually affect the lower esophageal sphincter to a great, I mean, you'd have to consume a lot of carbonated beverages.
Eating close to bedtime.
Okay, that can precipitate the gastroesophageal reflux. Okay, if they eat within 2 hours or so of going to bed, they eat and then lay down. Yeah, that's not a good thing. But risk factors such as obesity that actually puts pressure on the stomach there. Okay, excessive alcohol consumption, smoking, hiatal hernia, and pregnancy. Okay, so those things. Anything that's gonna, that'll, you know, determine the LES, the lower esophageal sphincter incompetence, okay, or is a risk factor for that. So the problems with GERD are pain, ineffective health maintenance. They need to be ready to learn about changing their lifestyle and nutrition possibly, and they have a risk for aspiration. So the goals, we want to relieve their discomfort, heal any erosion, and for them to adhere to those changes. So the interventions, okay, to decrease that pressure on the stomach, what might be a good thing?
Small frequent meals.
Okay, that helps keep the pressure from increasing in the stomach and putting pressure on that LES. Okay, what else?
Staying
You
vertical.
add extra pillows. So they're
Okay, they need to sleep on more than one pillow, possibly 3 or 4, or put blocks underneath their headboard, lift up the head of the bed mattress. Or a lot of people now have those beds that they can elevate the head of the bed, similar to a hospital bed. What about foods?
Acid food, alcohol.
Okay,
Orange
so
spicy
orange
food.
juice, tomatoes, tomato sauce, coffee, alcohol, smoking, and
Spicy
chocolate.
foods.
Okay.
Yeah, spicy too.
Spicy can. Okay, so it's important for that patient because one food may do it and another food may not. So it's important for them to know what those trigger foods are and any activity that's going to stimulate that acid production, including stress. Okay, so elevate the head of the bed at least 30 degrees. They've got to avoid wearing tight-fitting clothing right around the abdomen. Nothing that's painted on, nothing that's too tight. That, you know, it's important for them to maintain ideal or near body, ideal body weight. Except if they're smoking and drinking, even maintaining, ideal body weight's not going to help them if they have that incompetent LES. So pharmacologically, they may be taking antacids such as Tums, okay, calcium carbonate, and that is for very intermittent GERD. Okay. An H2 receptor blocker, a histamine 2 receptor blocker, such as ranitidine or famotidine. So it's going to be that DINE ending, you know. So those things, you need to know the mechanism of action by which those medications work. PPIs, proton pump inhibitors, directly reduce gastric acid production. And that's pantoprazole, which is Protonix, and that's the drug of choice in the hospitals. Omeprazole, omeprazole, esomeprazole, okay? Promotility agents to help with emptying, such as metoclopramide or Reglan. If those meds don't work, there is a surgery called fundoplication where they take the gastric fundus and it wrapped around the lower esophagus to narrow the opening of the LES. So it can be done laparoscopically, or the open procedure is called a Nissen fundoplication, N-I-S-S-E-N. Okay, and we always, always, always want to evaluate what's going on. You know, those lifestyle changes are not going to be easy for people, you know, in this area that need to, you know, things like, you know, fried food might stimulate that gastric production, or the high fat along, you know, with the bile and stuff and that anything made with a roux, anything, you know, and there we go. All right. So now I didn't get a chance. IBD is at the end, and I didn't get a chance to go over that with the first group. I may not get a chance to go over that with y'all, but I will put that on the discussion board. I decided in between that I'll put notes on the discussion board for you guys to refer to, or I may actually put them on the Canvas site. You'll know, because I'll send a, you know, I'll send a message. So as we go to hepatitis, hepatitis is what? Generally.
Liver.
Okay, the inflammation of the liver. It could be by a virus that we're going to talk about, alcohol, medications, toxins, and autoimmune disorders or other pathogens that damage cells. Okay, inflammatory process could be mild, like with hepatitis A, where there's no significant damage, but it still lasts 9 to 11 weeks and has an influenza kind of flu-like symptoms, okay? Whereas hepatitis B and C can lead to significant damage and cirrhosis, okay? And which is liver failure and possibly transplant, depending. Okay, so the liver produces bile, right? That's stored in the gallbladder. What does bile do?
Emulsify fats, break down fat.
Break down fat, good. Okay, also the liver handles and processes nutrients carried from the small intestines via blood. What else does it do?
It metabolizes drugs.
Yeah,
It
talked about that.
clotting factors. Your
There
clotting
you go.
factors.
It manufactures clotting factors, which then precipitates what for that patient? What is one of those problems they're going to have? If they don't have the clotting factors,
Then they're gonna bleed out.
okay, they're going to have bleeding. Okay.
Mm-hmm.
So the assessment for hepatitis, incubation are going to be no symptoms. And then prodromal 2 weeks after exposure, they're going to have flu-like symptoms. Okay, mild but chronic right upper abdominal pain or epigastric pain. They may have some fever associated with it, some nausea and vomiting, anorexia, myalgia, arthralgia, which basically is body aches, or they may have anorexia. They just don't feel like eating at all. Okay, they can also experience jaundice. What does jaundice come from?
It's the presence of bile throughout the rest of your body.
It's an increase in bilirubin,
Right.
which is the breakdown, part of the breakdown of red blood cells. It breaks down to bilirubin and biliverdin. Okay? So bilirubin is yellow, biliverdin is green. So when you're puking your guts up, you see that yellow-green substance? There you go. Okay? So icteric, with the onset of jaundice, is that phase, and it's 5 to 10 days after those initial symptoms, caused by impaired bile flow throughout the biliary system due to the inflammatory process. Inflammatory process can cause what? What are those hallmark symptoms?
Redness, swelling, edema.
Okay, so edema, right? We talked there, we already mentioned the pain and that stuff, but the edema. So the edema can definitely close up those ducts and make it difficult for any bile to pass through. Okay, and causes that process. Now, some people don't ever develop jaundice. Okay, especially mild cases like hepatitis A. But the urine may be dark due to the bilirubin as well. And it's, again, from the breakdown of red blood cells. The convalescent period is 2 to 3 weeks after the acute illness, and signs of improvement include decreased abdominal pain. If they have jaundice, it starts to disappear. They'll increase, their appetite will increase, and so will their energy level. And those with hepatitis A usually resolve within 9 to 11 weeks. Okay, so complete recovery depends on the type of virus and then the treatments. Hepatitis A, how do they get that?
Fecal oral transmission.
Fecal.
Okay, fecal oral from contaminated food and water. Okay, are there vaccines for hepatitis A?
Yeah.
Yes.
Okay, 2 vaccines. What is the best way? If you can't afford vaccines and
Hand hygiene.
hand hygiene, exactly, especially with preparation of foods, okay, and water. If you're going out of country and that particular country does not have water sanitation like we do, it is recommended to get the vaccines. Okay, so again, lifestyle choices are very important here. Alcohol, excessive alcohol intake is going to cause malfunction in the liver. Illicit IV drug use. Okay, multiple sex partners, as well as unprotected sex and risk factors. Obesity, they get those people with lots of belly fat can end up with non-alcoholic fatty liver disease. Those with diabetes, high doses of acetaminophen. Took care of a 15-year-old pediatric patient that tried to commit suicide by taking a bottle of Tylenol. The parents were relieved that it was Tylenol. However, does anybody know what the antidote for acetaminophen is?
Mucomist.
Right, which is acetylcysteine. Smells like rotten eggs, not real palatable. Sometimes you have to give it through NG tube if they won't drink it or whatever. So, but it combines with it, gets it out of the system, hopefully within time. You know, you're thinking 15-year-old kid, you know, no problem. No, the liver was irreparably damaged. He was going to have to be on a transplant list. So, you know, when you're talking about something just innocuous like Tylenol, you think, it's not a bad drug. Well, yeah, it's very hepatotoxic. So what is the recommended daily cap on acetaminophen?
Less than 4.
Less than 4,000 milligrams in 24 hours. However, most institutions don't like to go above 3,000 milligrams or 3 grams a day. So that means that if you've got somebody with a fever and they're taking some kind of oral pain medicine, a lot of times it's got acetaminophen in it. So you're going to have to count and make sure they're not getting more than their allotted amount. So prevention is the key for these. Now, you know, they've started giving the vaccines for hepatitis B to infants and stuff. So, you know, all those people coming up should have, you know, all their vaccinations on board, but not all the time, because some people don't believe in vaccinations and things. So hepatitis B is still out there. People can get it from what?
Bloodborne.
Okay, sexual contact with contaminated blood or body fluids and shared needles.
Vertical transfer from the parent to the child.
Not sure. I know it could go in the breast milk. So, you know, but they, you know, that is all discussed prior to, and that's why when women are pregnant, they go through the whole series of, you know, any sexual RPR, sexually transmitted diseases, if they're positive for herpes zoster virus, if they're, and then their hepatitis B titers, you know, the hepatitis titers. Hepatitis A and hepatitis E are both fecal oral. Okay, good hand washing. Hepatitis A has the vaccines. Hepatitis B, there is a cure of such, or not so much a cure, but an antiretroviral drug for chronic Hep B, and it's tenofovir. I'll put it in the chat. Tenofovir disoproxil fumarate. That's always fun, huh? So anything that you're going to be given that is supposed to help the liver can also be what? Toxic to the liver.
Mm-hmm.
Also, with these antiretrovirals, they have to be very careful and monitor renal status, okay? And how are we going to do that? What kind of labs?
Creatinine bun, if you monitor.
Okay, it's not bun. It's BUN,
creatinine.
blood urea nitrogen, BUN and creatinine together, okay? Hepatitis C, usually get that from shared needles. History of HIV, receiving blood products before 1987. They didn't start screening till after that. Okay, and that's going to be things like sofosbuvir, based regimens and Harvoni, Epclusa, those kinds of things that can show a 90% overall cure rate for actually hepatitis C, okay? If they have Hep D, that means they have Hep B also. All right. And to determine the extent of liver impairment, there is what we call a liver profile or the liver enzymes, and that's ALT, alanine aminotransferase, AST, aspartate aminotransferase, ALP, alkaline phosphatase. Okay, those are all in your lab sheet. GGT, the gamma glutamyl transferase. Okay, serum bilirubin and albumin are important with this. And also looking for the antigens to determine what kind, if it's hepatitis, well, if it's a viral hepatitis, A, B, C, D, or E. Okay, they can also do a liver biopsy. So we want to decrease their pain. They're going to have some pain in that right upper quadrant, but we need to avoid acetaminophen, aspirin, and ibuprofen, which all can be toxic to the liver. Okay, they need to use protective measures to prevent the spreading. So again, they need to, it's an infectious disease, it's reportable. We need nutrition and dietitians on here, GI, teaching them good hand hygiene, okay? Supportive therapy such as rest periods for fatigue, proper diet, nutrition. They need to avoid alcohol and drug use. So again, counseling and social services and referrals to support groups. Pain meds, antipyretics, we have to be careful with those. Smaller meals and use of snacks need to be used to maintain increased caloric intake for healing. They can have a risk for impaired skin integrity. It can cause itching, okay, when the bile salts come through the skin. So what interventions do you think we would use for that?
Mittens during sleep.
Wait, come again?
Like wearing mittens during it while you're sleeping, if it's like a kid, so they don't itch themselves.
Well, what, I mean,
No, they'll scratch. They'll scratch. So we need to,
Get an order from the doctor to cut their nails.
okay.
what about,
Wait, let's go. The cutting of the nails. Okay. So what if they're confused? You know, they get combative and stuff. So you can't teach them not to scratch. What's an alternative that is not a restraint?
The mittens.
No, mittens are a restraint because they can't use their hands.
why we can't use
Someone
Benadryl?
sitter. You can get
Yeah.
a sitter to sit with them.
Even more basic than that. You
Why we
buy them
can't-
gloves,
Gloves.
those white cotton gloves
Oh,
where they can still
yeah.
pick up things and do things for themselves, but they're not going to cause breakdown when they scratch. Okay, the first thing you're going to do if you notice that is you're going to give them, wipe them down. Okay, not with a lot of soap because it gets rid of the oils, can dry their skin. Dry skin's going to make them itch more. Okay, real hot water is going to make them itch. Cold water is going to give them goosebumps that'll make them itch. So you want to make sure it's just kind of very lukewarm. okay, but to help get rid of the bile salts. And then you can use some Benadryl cream. Okay, you can also actually, without the Benadryl cream, just lubricate their skin with lotion. And you can give them Benadryl or diphenhydramine. Make sure you know that that's the generic, but you've got to give them proper doses at the proper times. So you need to know those intervals. Okay, so yes, trimming the fingernails, but the cotton gloves are really a godsend. And the mittens, though, see, impair them using their hands to get a cup of water or to get, so, but the gloves, they can still perform things for themselves. Okay. So again, the pharmacological, the antiretroviral drugs, the immunizations, and lots of education for the family and significant others. Okay, so moving on. And of course, we want to evaluate how all this is working. Are they able to start, eating? Are they still nauseated? If they're nauseated, what is the drug of choice nowadays?
Finnegan.
Finnegan.
No. No.
Yeah.
Why?
I know.
Okay.
Ondansetron.
It's Zofran, or ondansetron is the generic for Zofran. Phenergan causes what besides relief?
Sleepiness.
Okay, it
Necrosis of
says
the
sedative effect. Okay, so if you've got somebody that's nauseated and vomiting, okay, and you're not sure where it's coming from, could be a head injury. You don't want to sedate them so that you can't see a change in level of consciousness. There are a lot of different things that you don't want to really sedate them for. Okay, so Zofran is going to be that choice. And thank God for the pharmaceutical companies coming through with that for chemo patients, and then for them to cross over to med-surg, because yes, when we're talking Phenergan, we're talking Vistaril, we're talking all those kinds of things, like I said, it definitely makes a difference in neurochecks. If they're getting pain medicine every 4 hours and they're mixing it with Phenergan, it keeps them in that state where they're in a fog. You can't, it's hard to do things with them, much less safely get them up to the bathroom or ambulate. So, pancreatitis, definition. What is it?
Inflammation of the pancreas.
Exactly. Okay. So it's going to affect the release of pancreatic enzymes into the duodenum through the pancreatic duct. Okay, that joins the common bile duct and empties into the duodenum. Those enzymes are usually activated in the intestine, and they're used to break down proteins, carbs, and fats. Okay, in the inflammatory process, again, what happens? We're not going to see the redness, but inflammation causes edema. When we're talking about ducts, it can swell the opening of that to very small, if not close it. Okay, so when those enzymes are secreted towards, or if they have a gallstone, God forbid, that's blocking there, and it causes a reflux back into the pancreas. Okay, those enzymes can cause autodigestion in that pancreas. It starts breaking down the tissue of the pancreas. And that's what really causes the pain. Alcohol is the big cause of pancreatitis and can cause that those ducts to swell closed. Okay. So with that, they can end up with hemorrhage, necrosis of the tissue, nausea, vomiting, weight loss, constipation, flatulence, and steatorrhea, which are those fatty, frothy, foul-smelling stools. Okay? And then gallstones or alcoholism for either the obstruction of the pancreatic duct or the edema to cause, that increases the pressure and causes it to come back with the auto digestion. NPO is critical at this point. If there's a suspect of pancreatitis, you need to put the patient NPO, because drinking something, eating something is going to cause the excretion of those enzymes. They're not going to get through. They're going to come back to the pancreas and cause more damage to the pancreas, right? Okay. So anybody thinking, why not just give them pain medicine? Pain medicine isn't going to help if you still allow them to eat and drink. You can throw all the pain medicine you want at it, ain't going to happen. They have to be NPO. They're going to be NPO for more than 2 or 3 days. They're going to start them on TPN because that bowel needs to rest. The edema and the inflammation needs to decrease so that the edema decreases or the obstruction is released if it's a gallstone, and that would be by taking the gallbladder out and removing that stone. Okay, so there's got to be some kind of release. Okay, then there can be tissue ischemia and anoxia. So all those things, 3rd trimester pregnancy, believe it or not, can cause an acute interstitial pancreatitis. Doesn't necessarily cause permanent damage. It just is what it is during pregnancy. Sometimes infectious agents, so they're going to have to put them on antibiotics if they have abscesses. Okay, meds such as NSAIDs, thiazide, diuretics, estrogen, salicylates, and steroids can also cause pancreatitis. All right, and then it'll cause the vasoactive substances released with that autodigestion, causes vascular damage and vasodilation. With the vascular damage comes hemorrhage, which in turn can precipitate that internal bleeding, the Cullen sign and the Turner sign. Vasodilation, increased vascular permeability, resulting in edema. Okay, with the pancreas and the fluid shift to the abdominal cavity. So it can cause ascites. When you have that fluid right up against that diaphragm, complications include ARDS, adult respiratory distress syndrome. Pancreatitis that becomes chronic, those alcoholics that have trouble, abstaining from alcohol, when it becomes fibrotic, the pancreas, and the tissue is destroyed, it's irreversible. Okay, so they're going to have to, because those enzymes then are not going to be produced, they're going to have to take pancreatic enzymes before meals to digest those foods. If they're enteric coated, they're good. They need to take it before the meal, just not with any milk products. If not, the pancreatic enzymes need to be taken with an H2 receptor blocker to decrease that, or a PPI to decrease that acid content in there. Let the enzymes do their job, and then for the patient to eat. So not only does it have that function, but what else does the pancreas do?
Helps with insulin secretion.
There you go, production and excretion of insulin. So if the pancreas is malfunctioning, what can that mean for that patient?
I mean, insulin production is inhibited or slowed.
Mhm.
So high blood sugar.
You need to monitor their blood sugar.
They can end up with diabetes, because remember, this
Wow.
is irreversible. Okay, so they can end up with diabetes. Okay, sometimes this pancreatitis can be initiated by a fatty meal or excessive alcohol intake. Sometimes it's relieved by sitting up or leaning forward. Like I said, they have nausea, vomiting, abdominal distension. Now, they can develop abscesses that can perforate into the abdominal cavity, okay, the peritoneal cavity. That's called peritonitis. Okay, they can get that from PUD when ulcers perforate, as well as if the gallbladder perforates or necrosis in the gut. Okay, peritonitis is characterized by sudden onset of abdominal rigidity, extreme pain, okay, decrease to no bowel sounds, tachycardia, hypotension. They'll get a temp almost right away. They'll get cold and clammy, and they can go into shock. And like I said, acute respiratory distress syndrome. So, and renal failure, et cetera, et cetera. So that's going to have to be fixed surgically. They're going to need to go in, you know, if it's the gallbladder, they're going to need to take that out. If it's pancreas, they're going to have to drain the abscess, put a tube in there, close whatever they can, okay, and clean out the peritoneal cavity. And start them on some real good antibiotics so they don't become septic. Like I said, chronic, they're going to have recurrent episodes of acute exacerbations as well as just chronic. They're going to have weight loss. So you're going to be weighing them daily. Okay. They're going to have signs of malabsorption, malnutrition, and possible peptic ulcer disease. Okay, and opioid addiction can be common to frequent severe episodes of pain. Think about it. They're addicted to alcohol, which is 80% of the cases of pancreatitis. Okay, they can be addicted to the opioids as well. So the diagnostic tests are going to be serum amylase. So if I use the Simoji units or even the regular units, either deciliter per liter or per deciliter, anything over 170 is going to be indicative of inflammation in the pancreas, and it'll rise 2 to 12 hours after the onset. Okay, and it'll return to normal somewhere 3 to 4 days, depending on the duration though of the pancreatitis. Serum lipase, again, we're looking for 20 to 180. So anything over 180 international units per liter. Anything less than that is going to be normal, but anything over that is it's going to be elevated for 7 to 14 days in acute pancreatitis. We talked about the glucose increase, right? And then we need to look at all the liver enzymes as well. Again, it can be diagnosed with ultrasound and CAT scan, are the least invasive and can diagnose. You know, they can do an aspiration biopsy, they can do all these other things, but they'll look for gallstones, they'll look for a cause. Now, one of the things with pancreatitis, we also have to be mindful if they're going into alcohol withdrawal. Okay, they're going to need thiamine, they're going to need replacements, and we need to be mindful of seizure activity. So they're going to get opioid analgesics, you know, morphine or hydromorphone, Dilaudid for pain. That's administered PRN It's better if they get it per PCA, patient-controlled analgesia. That way they have control. They'll usually get a basal dose of that pain medicine, and then they'll be locked out at a certain amount they can give themselves per hour. But what you usually find when they administer PCA, that they use less than if they were calling for it, because they don't have control. They'll be on that button every 2 hours, and they get those peaks and valleys when it goes in IV, and then they come down. Whereas usually PCA keeps them on more of a steady threshold with little bitty hills, as opposed to these big rise and falls of pain. Okay. So again, NPO, TPN, they may even put an NG tube to suction to promote organ rest and reduce those pancreatic secretions. IV fluids, okay, for hydration status, weighing daily, we talked about that. Antiemetics is ordered, frequent oral hygiene. We want to assess the bowel movements and monitor that I&O. They could be having that third spacing into the abdominal cavity, the ascites, so we're going to monitor their abdominal girth. Monitor for hypovolemic shock, level of consciousness and behavior, signs and symptoms of alcohol withdrawal, hypotension and hypoxia may decrease cerebral perfusion again. So we want to make sure to monitor for that. Okay. And then education on lifestyle changes. They have to abstain from alcohol. Have to. Okay. A lot of times they'll prescribe a low-fat diet, but that usually comes in conjunction if they have to remove the gallbladder due to gallstones clogging that duct. Okay, I'm gonna give you 10-minute break till 20 minutes of 12. Okay.
I have a question really quick,
Sure.
Miss Lee. I know for it was for was it for hepatitis, the GGT, that is not on our live value sheet.
Okay. And actually, I thought it was, but if it's not, then don't worry about the lab value for the
Okay.
GGT. Usually what you're going to see with those it's the liver profile, the AST, the ALT, the ALP, the bilirubin, okay, total protein and
Okay.
albumin. Yeah. Okay. All
Okay,
righty.
so the main thing is worrying about the liver profile.
Yes, because that's going to be indicative to the extent of the damage that's going on with the liver. Okay, see you in a few. All right, you guys, we're back. So we're going to talk about peptic ulcer disease. Okay. So definition is a break in the mucosal lining of the GI tract where it comes in contact with the gastric juices and is a chronic health problem, right? So ulcers develop when the mucosal barrier is unable to protect the mucosa from damage by hydrochloric acid and the pepsin, or those gastric juices. It's more common in smokers and those who are chronic users of NSAIDs. Alcohol may exacerbate the disease, but does not seem to cause PUD, as dietary intake does not cause PUD either. Okay, stress causes increase in gastric acid production, okay, but doesn't necessarily cause ulcers. But if you look at it as increasing gastric acid and that you're prone to that, to ulcers because of that, then yes. The bacteria H. pylori or Helicobacter pylori infection is found in 70% of patients with PUD. And it's spread from individual to individual by oral or fecal to oral or fecal to oral, by contaminated water and or food preparation. You know, be careful of restaurants and things like that. They need to have excellent hand washing. People that are preparing foods inside the home, again, you know, watch cross-contamination and good hand washing again. NSAIDs also contribute to peptic ulcer disease and causes damage to the cell themselves. So it may be chronic with spontaneous remissions and exacerbations. They can be associated, exacerbations can be associated with trauma, infection, or other physical or psychological stressors. Caffeine can exacerbate the disease. Smoking doubles the risk of PUD. And a family history definitely is a risk factor. Also, use of glucocorticosteroids, okay, steroids. So you might, in your clinical setting, you might come across a patient that you're giving a proton pump inhibitor to, Protonix, okay, and or Zantac or something of that nature, ranitidine, and say, well, they don't have a history of PUD and I don't see one of GERD. It could be prophylactically from stress of the hospitalization and or tests. If they were ventilated at one point with mechanical ventilation, all those kinds of things. ICU stays, they all precipitate stress, okay, that can lead to increased gastric acid production. So again, the abdominal pain is classic, the gnawing, burning, aching in the epigastric region that can radiate to the back, occurs when empty, usually relieved by eating, can cause nausea, vomiting. Complications include GI hemorrhage or perforation that can lead to peritonitis. Now, the GI hemorrhage, if you're talking about a bleeding ulcer, it can, you know, be blatant, which is going to be vomiting blood, in which case you need to put down an NG tube and start sucking it out, okay? So, and then replace with, again, isotonic fluids and blood, and until you can get the blood up there and replace the volume that's being lost. You have to watch for hypovolemic shock that includes low blood pressure, tachycardia, right? Okay, so you need to you know, be vigilant with that. If it looks more coffee ground, kind of black and kind of clotted, okay, that means it's a slower bleed. Okay, and they could probably get a handle on it, as opposed to something that's vigorously bleeding and it's frank red blood that's being sucked out. And those are usually upper ulcers in the upper stomach. Okay, in the duodenum. Okay, duodenal ulcers, a lot of times it will make its way through the intestines. The blood will, when it's bleeding. If it's digested, okay, part of the duodenum and it's going through digested blood is melena. Okay, and it's black and tarry, and it gives a very distinctive smell. If it's an active bleed that becomes more profuse and they're hemorrhaging, it'll come out red and gelatinous. Okay. So you need to watch your vital signs. If they're tacking and their blood pressure's dropping, they've got to be bleeding from somewhere. Okay. And then especially if they start hurting, and then you've got to watch to make sure that that pulse doesn't drop. That's the compensatory mechanism, the tachycardia, when that blood pressure drops. If that pulse starts dropping, that's when they're going into shock. Their volume is critically low and needs to be replenished by that blood. Okay, they can suffer from anoxia, decreased cerebral perfusion, level of consciousness, all that kind of stuff is going to be impaired. So again, perforation, they're going to need to take them straight to the OR, repair that perforation, keep that in NG tube down there and repair that. Now, sometimes they can do that. The Hallmark diagnostic test, if you will, for peptic ulcer disease, usually if it's going to be diagnostic in the GI clinic, they're going to give them a little bit of propofol and do an esophago-gastro-duodenoscopy, just like I told you for GERD. They can visualize the redness, the erosion, okay, edema, and everything going into the stomach and the duodenum, right? Esophagus, gastro, meaning stomach, and into the duodenum. So that's the hallmark for GERD, to make sure to visualize the redness and all of that, and the erosion. And then again, for peptic ulcer disease, so they can do biopsies with the ulcers that are there to be able to see if it's the Helicobacter or if it's NSAID. And usually they can visually tell the difference. If it's a bleeding ulcer that hasn't perforated all the way through, they can also go down that way and put a clip over the ulcer and clip it closed so that it does not bleed anymore. Okay, least invasive, most productive way to do that. Okay, they may give a little bit of opioid analgesic right after that, but otherwise it's all going to be the Protonix IV drip they have them on, the pantoprazole drip, to decrease the acid production to allow that mucosa to heal. They may put them on the sucralfate or bismuth, which is going to help coat the stomach, okay, and help that mucosa heal. And then, a PPI, an H2 receptor blocker on an ongoing basis. So an EGD is going to be your, the hallmark for that. So when they put down the scope, I told you about the propofol, it's just easy, quick. And the nice thing is, if that patient's in ICU because of the bleed, they bring the equipment to them. They don't have to take them to surgery. It's a procedure. But the things with this, if it's just, an outpatient setting, they don't do any kind of procedure unless your vital signs are stable and normal, within the norm limits. Okay, because afterwards they're going to take vital signs for a certain amount of time, and any increase in that heart rate, decrease in blood pressure that can denote a complication such as bleeding, or some kind of traumatic event. They may have a sore throat. They may be a little hoarse, but they shouldn't be running a fever. Their vital signs should not be, or an elevated temp. Their vital signs should be within normal. Okay. So if it's an H. pylori infection, meticulous hand washing with meal prep and everything, they will put them on drugs to decrease the gastric acid, and then meds to protect the mucosa, as well as antibiotics to be able to get rid of the infection itself. So like triple therapy would be 2 antibiotics, mycin, clarithromycin, and amoxicillin, either one of those, and metronidazole, which is Flagyl. And they'll use that with a PPI or an H2 blocker for 10 to 14 days. The quadruple therapy, again, the 2 antibiotics with a PPI or H2 blocker and bismuth or sucralfate. And that, again, stimulates the mucosal bicarbonate prostaglandin production so that it stimulates them to be able to repair themselves. And bismuth, make sure that can darken the stools. So if you're talking Pepto-Bismol that has bismuth in there, the stools will be darker. But in order for a GI bleed to happen, it's got to be, the black and tarry looking stools, not just a darker normal stool. Okay. So again, complication, the peritonitis, the hemorrhage, you're going to monitor CBCs, the basic metabolic profile. If they cultured those ulcers, they're going to look to see if the Helicobacter comes back, the Helicobacter pylori, so that they can treat them with antibiotics. Assess the abdomen, again, bed rest with head of bed elevated, manage the pain. So teach relaxation and stress reduction, okay? Promote balanced nutrition. There is no real diet restriction for those that have PUD. Smoking cessation is encouraged. Alcohol can exacerbate, doesn't cause it, but can definitely cause pain, smaller meals, and anything that can trigger the pain you want to stay away from. But again, opioids are not usually used in relation to peptic ulcer disease. So when we talk about gallbladder disease, cholecystitis is the inflammation of the gallbladder, and it alters the flow through the hepatic, cystic, or common bile duct. And the common problem is gallstones, formation of gallstones, which are usually mostly cholesterol. And that's when they call it cholelithiasis. Okay. So again, with cholecystitis, if a gallstone comes out and blocks that common bile duct, it can cause reflux of the pancreatic enzymes back to the pancreas and cause pancreatitis. It can cause problems in the liver because the bile doesn't get through, backs it up into the gallbladder, backs it up into the liver. Okay, so things like the liver profile, the ALT, AST, ALP, the bilirubin and all that needs to be looked at. They'll do serum amylase and lipase to see if the pancreas is involved at all. They're usually going to have the right upper quadrant pain that can radiate to the back, right scapular or shoulder. The colic usually lasts as long about 5 hours after a large fatty meal. Okay. And so that's the colic, and it's usually accompanied by nausea, vomiting. And so, and then it goes away. And a lot of people will have that chronicity of those kinds of attacks until it gets to the point where, like I said, that duct is completely blocked. And then it's severe pain. They'll have fever, they'll have, let's see, they can have, you know, low blood pressure and stuff, especially if it perforates. Okay, if it's gangrenous, cause infection to the point of gangrenous, can result in the peritonitis as well. So again, clay colored stools are not clay colored, not Mississippi red color clay, but gray colored, okay, is an indicative sign that they need to go to surgery right then. And then the hallmark diagnostic test is going to be an ultrasound, because they can visualize the gallbladder. They can see thickening of the wall, any sludge that's present in there, and any stones and they visualize the ducts. So the first thing is going to be pain for them, you know, as well as they're going to be diaphoretic and things. So we're going to start IVs. We're going to help reduce their pain, but we're going to put them NPO first, because more than likely they're going to go to surgery. Okay, they're at a risk for infection, so they're going to start some antibiotics. We're going to do pre-op teaching, and so we're going to go ahead and get them ready for surgery. So we want to prevent infection. You know, again, hang antibiotics as ordered, pre and post-op, promote effective pain management. They will get opioids pre-op for the pain. They will get it post-op for a short amount of time. Okay. If for some reason they have nausea, vomiting, or they're not a good candidate for surgery, we'll put down an NG2 to help decompress, right? They'll be NPO, and then they may do a lithotripsy, bring them to the lithotripsy lab, and they give them some mild sedation. It's an ultrasound that gives them shock waves, basically, to dissolve, kind of disrupt those large gallstones and make them smaller or make them into sludge so that it can pass. They can pass them. Okay. We would monitor for the biliary colic, the pain, nausea. There may be some transient hematuria. Okay. And then they will be put on either ursodiol or quinodiol to help bind with cholesterol and be able to excrete it. But they have to keep on that, or cholestyramine, if you've ever heard of that. They'll keep them on those drugs to bind with the cholesterol so that it can be excreted, and they have to stay on that drug for life. Okay. If for some reason, when the stones are lodged in the duct, okay, and they have to do an exploration of the CBD, they may have to insert a T-tube once that gallbladder is, the gallstone is removed, a T-tube, and it's like a little stent with a drainage pouch on it, okay? And to drain the bile, okay? And keep that passage open while the inflammatory process kind of reverses and the edema goes away, okay? The excess bile is collected in that drainage bag and can be up to 500 milliliters in the first hours. That's normal, but it should decrease to less than 200 milliliters in 2 to 3 days, okay? If it gets worse, then we need to definitely explore that and see what's going on. So that's contact the healthcare provider, but it should get better. And like I said, that 200 milliliter mark within 24, less than 200 milliliters in 2 to 3 days. They also need to be counseled about balanced nutrition and a low-fat diet, okay? Kill them again down here. Fried foods, anything made with a roux, all those kinds of things, because fat soluble vitamins, you never really think about that, but those need to be broken down as well. So all of those things, surgery is going to be the main thing. Laparoscopic for incisions, small incisions, they go in, they're able to cut it and remove the gallbladder, okay, and visualize anything else in the ducts and stuff and be able to make sure the peritoneal cavity is clean. Easy, less than 24 hours in as far as a hospital stay, very little infection, as far as it's just little bitty incisions. So the healing, the downtime, and the infection rate is very low, okay? They may give them prophylactic antibiotics just to make sure post-op as well as the pre-op, and then opioid analgesics for a small amount of time. Usually no heavy objects greater than 10 pounds as far as lifting. Now with the laparoscopic, they put gas in that peritoneal cavity so they can visualize all those organs and be able to see what's going on and get them out. Okay, they may have referred shoulder pain from the gas getting trapped, okay, by nerve clusters. So it's going to be a K-pad to warm, kind of vasodilate things so that it can be absorbed. But K-pads don't get very warm. You don't want them using a high heating pad because that can cause what? Especially after surgery. Bleeding, right? Causes the vessels to vasodilate and can cause bleeding. So very, more like heating up a little towel and putting it on there, under hot water and putting that over there and just changing position. Motility, being mobile, up and ambulating will help with the motility and help with getting rid of that gas that's there as well. Okay. Any questions about that? Okay. So you're going to teach them when they're not in pain and all that kind of good stuff about low-fat diet. All right, but otherwise they should be good. Again, the labs that are going to be with that, I went over those with pancreatitis and liver, as well as the CBC for infection, those kinds of things. Okay, so we're going to get to inflammatory bowel disease, which is a collection of chronic inflammatory conditions of the intestines. They have periods of remissions and they have periods of exacerbations. where the disease is active and acute, okay? So ulcerative colitis is basically just involves this mucosa and submucosa of the colon and the rectum, okay? That's only where the ulcerative colitis is. Crohn's, however, can affect any portion of the GI tract from the mouth to the anus, okay? And usually kind of stays in is telltale for mid-abdomen and right mid to lower abdominal pain for Crohn's, okay? Although it can happen anywhere. Ulcerative colitis, the pain's going to be left lower, right? Where the colon is and the anus. Okay? So, ulcerative colitis, again, ulcers. They're going to have ulcers that can cause hemorrhaging and abscess formation and sloughing of the mucosa and can cause necrosis. The mucosa becomes red and edematous, releasing of exudates and everything, and it bleeds, like I said, bleeds easily. So when they have tenesmus or this pain associated with defecation with ulcerative colitis, you might see in those stools mucus and blood. Okay, they bleed very easily, and the chronic inflammation leads to atrophy and narrowing and shortening of the colon, where Crohn's is a skip lesion, where they may have a portion of the intestines here that's affected, and then it goes on and it's fine, and then another lesion. So if they, with ulcerative colitis, a lot of times they can take out a piece of the colon that's diseased and reattach it, reanastomose it, okay? And have it healed that way. Or if it's bad enough and the colon has, the tissue is friable, meaning it's hard to piece anything together, they may have to take part of the colon and have it come out with an opening to the skin, right? What is that called?
Stoma.
It's an ostomy, right? And the little outpouching of the intestines is called the stoma. It should be nice and dark pink and moist, okay? If at all it gets pale, starts turning blue, that is a medical emergency. Okay, the blood flow is being hindered from that, and they need to take them back to surgery. When it's for ulcerative colitis, it's going to be in the colon, so it's a colostomy. Okay, and usually that's formed stool, okay, in that pouch. When it's for Crohn's, it's going to be on the opposite side in the ileum, and it's going to be an ileostomy, and that's going to be more liquid, okay, liquid stool. And you're going to have to measure those, okay? So Crohn's is more canker sore type lesions of the mucosa and submucosa, and can progress to affect all layers of the intestinal wall. So they can have deep ulcerations. They end up with progression of Crohn's fibrotic changes, and they lose the flexibility of the colon, and it thickens. And then it starts sticking together. They lose the lubricant, if you will, okay, that makes things slide, the organs slide together. So they get sticky, they start sticking together, and they can form fistulas, which is what?
Connection of two.
Happening?
Okay, it's an unplanned connection, okay, or opening between two organs. An ostomy is a man-made fistula because they go in and actually cause an opening between the intestines and the skin. Whereas, okay, Crohn's a lot of time will be bowel to bowel, which really doesn't cause a lot of problems except for malabsorption and malnutrition. You will see that in Crohn's. Okay. And then also bowel and bladder. Now, what kind of problem does that cause?
Risk for infection, especially with.
Yeah, big time infection, right? Because it can go in the bladder and then find its way up to the kidneys, right? Because the bladder is a sterile organ, whereas the colon and the intestines are not, okay? And then I have also personally taken care of a woman that ended up with a fistula between the bowel and the vagina where feces were coming out of her vagina. Okay, and that's no bueno either. Okay, they can have development of abscesses as well with Crohn's. So, you know, with that assessment, you'll see fever. Their hydration status, because a lot of times they're going to have diarrhea stools that can be anywhere from 5 to 30, depending on, you know, the exacerbation of the disease and what's going on. Like I said, for the stool for ulcerative colitis, it's going to be blood and mucus. So that CBC is going to be important to look at that H&H and see if they're going to need a transfusion. They will have nutritional deficit involving anemia, hypoalbuminemia, which in other words, decreased albumin or protein, and weight loss, along with Crohn's. Okay, but Crohn's will also have multivitamin and mineral deficits as well. Ulcerative colitis, again, they can have toxic megacolon, perforation, which ends up in peritonitis, massive hemorrhage, and of course, increased risk of colorectal cancer 8 to 10 years after diagnosis with one of these diseases. So they need colonoscopies every 6 to 12 months, but not during an acute exacerbation. Because if they try and do a colonoscopy or sigmoidoscopy when they have an acute exacerbation, okay, it could end up with perforation and peritonitis. So what they'll do a lot of times is a CAT scan, you know, or an X-ray to see what's going on there. With Crohn's, there's no obvious blood or mucus in the stool, but they'll have steady right lower quadrant, or like I said, mid-abdominal pain or tenderness. They can have nausea, vomiting, epigastric pain if the stomach or duodenum are involved. Their big thing, common complication is obstruction, small bowel obstruction, to where the bowel, because of the fibrotic changes and things like that, just is closed and nothing's getting through. Okay, that's a surgical intervention. They're going to have to cut out that obstruction and reanastomose it or do an ileostomy to let, that is the ultimate in bowel rest for a Crohn's or an ulcerative colitis patient, is to form an ostomy. You know, a lot of times they'll wait and then reanastomose it several years, let all the inflammation die down. So perforation and hemorrhage are not common in Crohn's. Okay, but again, they have that long-term risk for development of colon cancer. So basically, acute and chronic pain relief, they're going to have risk for fluid volume deficit. They may have diarrhea. They may have some constipation associated with it. imbalanced nutrition, and disturbed body image if they have an ostomy. So we want to give them pain relief. It's going to be an opioid pain relief, okay? Adequate hydration that takes into account, we've got to be able to measure those liquid stools to replenish that, that fluid loss. Nutritional status, how are we going to maintain nutritional status?
TPN?
TPN, right, because they're going to be on bowel rest. Okay, they may not have an NG tube unless they have this nausea vomiting thing going on, but they're going to be on bowel rest. So they're going to be NPO. They may be able to have some ice chips, but that's it, and TPN. And then as the resolution of the symptoms come about, they will slowly add clear liquids and then other things. Now, they won't go to full liquids because they're not supposed to have milk or milk products. So they'll be on a low residue diet. Okay. High calorie, high protein, low fat. All right. They need the calories for growth and development, muscle mass healing, electrolyte homeostasis. So we need to monitor the CBC, their electrolytes, their total protein and albumin levels. And they may go ahead and get vitamin levels as well for those Crohn's patients. Okay. So they may increase the fiber for those to help reduce diarrhea and relieve rectal manifestations, but it is contraindicated for patients with intestinal strictures caused by repeated inflammation and scarring. Okay, so depending on where they are in the chronicity of things. INO, again, vital signs, they're going to be weighed daily. Again, that hydration status, so that we can monitor for that weight loss and for fluid volume deficit. Skin care, assess for perianal area irritation from diarrhea. A lot of Tux pads or those diaper wipes, peri-wash, and then use of calmeseptine to help. They want to use non-pharmacological methods for constipation, okay, such as ambulation, increasing fluid intake. And then pharmacologically, a lot of times they'll try and go straight to the colon with enemas and suppositories of mesalamine, also called Asacol or Ruwasa, that are non-sulfur containing preparations to help reduce the inflammatory process. They'll be on steroids initially. Do they want to be on steroids for any prolonged period? No, because of the side effects. Okay, so things now with the immunosuppressive agents, okay. Also, Entyvio, the vedolizumab, that's used for relief and remission so that patients can get off of steroids, very important. If they've got any abscesses, we want to use ciprofloxacin and metronidazole flagyl, okay, for abscess formation. And then, of course, if we're looking at colostomies or ileostomies, the characteristics of the stool, how much, okay, and watch the stoma. When you're cutting out an appliance, it has to be about 1/8 of an inch larger than the actual stoma, so that that stoma, if it swells, you're not cutting off that circulation there. Okay. Anybody have any questions?
I
'Cause we're
wanted to
done.
I wanted to ask real quick, you said you were gonna post some information about IBDs in the discussion board, but is that just for IBDs or is it gonna be for all of
No,
the?
it's just for IBD because the first class I didn't get to go over IBD with them. And, but the YouTube should cover it that's already posted. It covers the whole thing. So again, if y'all have any questions, that YouTube is there for you guys to refer to. Some of the drugs that I mentioned that could be on the test may not be in there. So just, you know, keep those drugs in mind and anything that I talked about there. And, you know, you guys should do fine.
Miss Leaf, I have a question.
Sure.
Earlier, when the young lady was saying mittens, and you said no because it was restrictive, in our textbook, volume 1 on page 251, under patient teaching for hepatitis, it states teach management apparatus and maintenance of the skin integrity, wear cotton mittens or gloves as needed to prevent scratching during sleep. So are we not including mittens? Is
We're
it
not
just gloves?
including mittens because they cannot take care of, you know, how are they going to press a call light if they need to? Okay. How are they going to, you know, reach for a cup of water if they're thirsty? Okay. So it is considered a form of restraint because it restricts them from doing things that they need to, you know, if they have to call because they're dirty, they have to go to the bathroom, or, you know, whatever.
Okay,
It's,
so
you
for
know,
testing purposes, even though the textbook states that, we'll just go
you
with
won't
gloves.
see mittens.
Okay, okay, thank you.
You're welcome. Anybody else? As you work with this material and you put them side by side and you look, you know, with IBD, I compared and contrasted those two, you know, but a lot of their pharmacological and interventions are the same. It's just where they occur and things. So work with this material and the exemplars to get that, you know, the diagnostic tests. You don't need 40 of them. I told you what the hallmark was, or the gold standard. Boom, there you go. The assessments, you know, what your assessment is, you go back and you look, what is the intervention for that assessment? What am I going to do for that? Okay, so all of those things are, you know, if the patient's NPO and they're on, you know, so, and they're dehydrated from nausea and vomiting, they need fluid. So they're going to be on IV fluids. And watch for those fluid and electrolytes, and we'll correct those as needed. Okay? Anybody else?
Thank you, Ms. Leaf.
You're welcome.
Thank you. Have a good day.
You too. Look,
you.
use the discussion board. Hang on. Use the discussion board. And real quick, in the chat, I'm going to put my my phone number. If the discussion board goes down on Friday and you're studying and it's Saturday or Sunday, hang on, I'm going to give you my cell number. There you go. Okay, you can shoot me a question that way.
Thank you so much.
You're welcome. Okay, I'll be more apt to answer it that way than by email.
Thank you, Ms. Lee.
You're welcome.
All right.